Right now, in medicine cabinets across the country, there's a pill that millions of people over 60 take every single night to fall asleep. It's not illegal, it's not experimental, most of it doesn't even need a prescription. And according to geriatric doctors, it may be more dangerous than the sleeplessness it's supposed to fix. Not might cause a headache dangerous, we're talking hip fractures, memory loss that gets misdiagnosed as dementia. And in the worst cases, it's linked to falls that seniors never fully recover from. Today I'm going to walk you through the 3 most dangerous sleep medications for people over 60, starting with one that's probably sitting in your bathroom right now, why they're so risky specifically for older bodies, and exactly what to do instead. Stick around till the end, because number 1 is the one almost nobody warns you about. If you're new here, this is the place where we break down real health research. The stuff your doctor doesn't always have time to explain in a 10-minute appointment, and turn it into plain, simple language. If that sounds useful, hit subscribe, because we post videos like this every week. And if you know someone over 60 who takes something to help them sleep, a parent, a spouse, yourself, do them a favor and send them this video. What you're about to hear could genuinely prevent a trip to the emergency room. Let's get into it. Now let me take a minute and explain something that will make everything else in this video make more sense. Most people don't realize that their body does not process medication the same way at 65 as it did at 35. Your liver slows down, your kidneys filter less efficiently, and the blood-brain barrier, the shield that's supposed to protect your brain from things circulating in your blood, gets more permeable with age, meaning more of a drug reaches your brain than it used to. So, a sleeping pill that worked fine for you at 40 can behave like an entirely different, much stronger drug at 70. Same bottle, same dose. Different body. This isn't a fringe theory. It's the entire reason the American Geriatric Society publishes something called the Beers Criteria, a list, updated by a panel of geriatric medicine experts, of medications that are considered potentially inappropriate for older adults, because the risk of harm tends to outweigh the benefit. And sitting right near the top of that list, category after category, sleep medications. Let's start with the one you've probably never thought twice about. The PM pain relievers. You know these products. Tylenol PM, Advil PM, ZzzQuil, that little PM on the label, promising you pain relief and sleep in one pill. Here's what almost nobody reads on the back of the box. The ingredient actually knocking you out isn't the pain reliever at all. It's an antihistamine called diphenhydramine, the exact same active ingredient in Benadryl. Manufacturers didn't invent a sleep drug. They took an allergy medication, noticed it makes people drowsy as a side effect, and repackaged that side effect as a feature. So why is this specifically dangerous after 60? Diphenhydramine works by blocking a brain chemical called acetylcholine. Doctors call drugs like this anticholinergic. And acetylcholine isn't just some random chemical. It's involved in memory, muscle control, and alertness. Now remember what I said about aging bodies a minute ago? Slower liver clearance means this drug stays in your system longer, and a more permeable blood-brain barrier means more of it gets into your brain than it would in a younger person. The result? The exact same dose that gives a 30-year-old mild drowsiness can leave a 70-year-old with next-day grogginess, confusion, and impaired coordination. The American Geriatric Society doesn't just caution against this drug. It's flagged in their official list of medications older adults should avoid, tagged with one of the strongest warnings on the entire list. Here's the part that should really concern you. Research has found that the majority of older adults using an over-the-counter sleep aid are taking one that contains this exact ingredient, and most have no idea it's considered risky at all. It's not a prescription. Nobody's watching the dose. Nobody's tracking how long they've used it. It's just sitting on a shelf next to the toothpaste. What this drug is actually linked to in seniors: next-day drowsiness and grogginess, the hangover effect, confusion that can look like early dementia, increased fall risk, constipation and urinary retention, dry mouth and blurred vision, And here's a finding that stopped me in my tracks while researching this. Some studies in aging health organizations have raised concern that long-term regular use of this type of drug may be linked to accelerated cognitive decline. It's not settled, proven science yet, but it's concerning enough that geriatric specialists actively steer people away from it. If you or someone you love reaches for a PM pain reliever specifically because of the sleep aid effect, not the pain relief, that's the moment to have a conversation with a pharmacist or doctor about safer options. We'll cover those later in this video. Now, drug number 2 on this list is the one most doctors are actually trying to move patients away from right now, in 2026, because for years it was marketed as the safe replacement for the drug we're about to cover in danger number 1. Turns out, it isn't nearly as safe as advertised. Z drugs, zolpidem, ezapaglone, zaleplon. You might know these by their brand names: Ambien, Lunesta, Sonata. In the medical world, they're nicknamed Z drugs, zolpidem, ezapaglone, and zaleplon. And for a long time, they were prescribed as the gentler alternative to older sleeping pills. Doctors believed they were safer, less habit-forming, easier on the body. The newer research tells a very different story. Here's the problem. Z drugs act on the same brain receptor system as older sedatives, something called GABA-A receptors, which is your brain's main calm-down signal. They were designed to be more selective, more targeted, but in practice, in older adults, the side effect profile looks disturbingly similar to the drugs they were supposed to replace. Let's talk numbers. One large nationwide study tracking hip fractures found something that should genuinely worry you. These drugs carried a noticeably higher risk of hip fracture specifically at night, the exact hours they're working as intended, compared to during the day. Think about what that means. The drug is doing its job, sedating you, at the exact moment you're most likely to need to get up, to use the bathroom, to check on a noise. And that's precisely when your balance, your reaction time, and your coordination are at their weakest. Older adults getting up at night are already at elevated risk. Add a drug that's actively suppressing your coordination and reflexes on top of that, in the dark, and you've built the exact conditions for a fall that leads to a broken hip. And hip fractures in older adults are not a minor injury. They're linked to a significant increase in mortality and disability risk, and they're one of the leading causes of older adults losing their independence entirely. But it doesn't stop at falls. Remember how these drugs work on your brain's calming receptors? Long-term use has been linked in research to something called pseudodementia, a temporary, drug-caused fog that can look almost identical to early dementia. Confusion, memory lapses, disorientation. Here's the scary part. This can get misdiagnosed. A patient shows up appearing to have new dementia, when the real cause is sitting in their medicine cabinet. Caught early, it's often reversible. Missed for years, the picture gets a lot murkier. There's also emerging research, still being actively studied, not fully proven, looking at whether long-term use disrupts the deep sleep your brain needs to clear out waste proteins linked to Alzheimer's disease. Some 2026 laboratory research has specifically investigated whether these drugs interfere with that overnight brain cleanup process. And here's something that might change how you think about sleep entirely. Being unconscious is not the same as being rested. These drugs suppress what's called REM sleep and deep slow-wave sleep, the two stages your brain actually needs for memory processing and physical restoration. Studies using brainwave monitoring have found that people on these drugs get more total hours of sleep, but less of the deep, restorative stages. That's the scientific explanation for why so many people wake up after 8 hours on these pills and still feel like they got hit by a truck. Now here's the trap that makes this worse. Your brain adapts to these drugs shockingly fast, often within about 6 weeks. It starts reducing the number of receptors that respond to the drug. The result? The same dose stops working as well, insomnia creeps back, and the natural response is to take more. That's not weakness. That's neurochemistry. but it creates a cycle. Dose goes up, tolerance chases it, and coming off the drug gets harder and harder the longer this continues. The American Geriatric Society's official guidance states plainly, these drugs have adverse effects similar to older sedatives in older adults, including delirium, falls, fractures, and increased emergency room visits, while providing only minimal improvement in how long or how well people actually sleep. Minimal benefit. Serious risk. That's the trade geriatric doctors are increasingly unwilling to make. Okay, we've covered the hidden allergy pill and the safer replacement that turned out not to be so safe. Now we're getting to number 1. This is the drug that's been prescribed to seniors for anxiety and sleep for over 50 years. It's one of the most commonly used medications in this age group on the planet, and officially, not from some blog, but from the actual American Geriatric Society guidelines, it is recommended to be avoided entirely for sleep in anyone over 65. Let's talk about benzodiazepines. Danger 1. Benzodiazepines. Alprazolam, Diazepam, Lorazepam. You probably know them by their brand names, Xanax, Valium, Ativan. Originally developed for anxiety, they've been prescribed off-label for sleep for decades. Here's where it gets genuinely alarming, and it goes back to that liver and kidney conversation from earlier. Your liver processes drugs 2 different ways. One pathway, called oxidation, slows down dramatically as you age, and several benzodiazepines, including diazepam, are broken down almost entirely through this slowing pathway. Here's the actual number. For every year past age 40, the time this drug stays active in your body increases by roughly 1 hour. Do the math on a 75-year-old, and a drug that clears out of a young adult's system in about a day can stay active in an older adult's body for over 3 days. That means if someone takes this pill every night, their body may never fully clear 1 dose before the next one arrives. The drug quietly stacks up in their system, even though nothing on the label or the prescription changed. And it gets worse, because some of these drugs don't just sit there, they break down into other active sedating chemicals in the process. So the liver isn't just slow to clear the original pill, it's manufacturing a slow-release cascade of additional sedatives along the way. Here's what the official Beers criteria says, word for word. Older adults have increased sensitivity to benzodiazepines and decreased metabolism of long-acting agents. All benzodiazepines increase risk of cognitive impairment, delirium, falls, fractures, and motor vehicle crashes in older adults. End quote. That's not a warning label footnote. That's the core, official recommendation from the leading geriatric medical association in the country. Let's talk about what increased risk actually looks like. A major nationwide study found that people using these drugs had a significantly higher risk of hip fracture, and the risk was highest specifically with the short-acting versions, the ones many doctors assumed were the gentler option. The research directly contradicts that assumption. Shorter-acting benzodiazepines are not safer than long-acting ones. Cognitively, long-term users can experience real, measurable deficits in memory, learning, attention, and spatial awareness. And troublingly, some research suggests these deficits don't always fully disappear, even after the drug is stopped. And then there's the dependency cycle, which is arguably the cruelest part of this whole story. Like we covered with Z drugs, your brain adapts to constant exposure by turning down its own receptors. But benzodiazepines also cause your brain's excitatory system to ramp up in the background, quietly compensating for months or years of artificial calming. Then, when someone tries to stop, even under a doctor's care, withdrawal can look like a mirror image of everything the drug was suppressing: rebound insomnia, anxiety, panic, muscle spasms, and in serious cases, seizures. This is exactly why we need to say this clearly. If you or someone you love is on one of these medications, do not stop taking it suddenly, ever. This has to be done gradually, under a doctor's supervision. quitting cold turkey can be genuinely dangerous. We'll talk about the right way to transition off these drugs in a moment. One more thing before we move on, because this affects millions of people simultaneously. New research published in 2026 has started connecting these drugs to something almost nobody talks about: heart health. A large population study following over 500,000 adults for more than a decade found that cumulative exposure to drugs like these, through a combined anticholinergic burden that includes several sleep aids, allergy medications, and bladder drugs, was linked to a measurably higher risk of cardiovascular events. Researchers are still working out exactly why, but current theories point to inflammation and disrupted signaling inside the heart itself. This research is newer and still developing. It's not as rock solid as the fall risk data, but it's one more reason geriatric doctors are pushing so hard for alternatives. So now you know the 3 drugs, but I promised you solutions, because the point of this video isn't to scare you into doing nothing, it's to arm you with what actually works instead. Stay with me, because this next part might be the most useful 3 minutes of the entire video. What to do instead first, and this is non-negotiable. Talk to your doctor before changing anything. Never stop a prescribed medication on your own. If you're on one of these drugs, the goal is a safe, gradual conversation with your prescriber, not an overnight change. Now, here's what geriatric medicine actually recommends as first-line treatment. Number 1, cognitive behavioral therapy for insomnia, that is CBT-I. This isn't a supplement or a gadget, it's a structured program, often just a few weeks, that retrains your sleep habits and the anxious thoughts around sleeplessness. It is genuinely the gold standard first-choice treatment recommended by geriatric guidelines, and it now comes in app-based and telehealth formats, so you don't need to live near a specialist to access it. And the next one, morning light exposure. Getting bright natural light early in the day helps reset your body's internal clock, especially important because aging naturally shifts and weakens that internal rhythm. Even 20 to 30 minutes near a bright window or outdoors can help. Then, a cooler bedroom. Research shows sleep quality drops once a bedroom gets warmer than about 75 degrees Fahrenheit. And for older adults specifically, overheated bedrooms have even been linked to added strain on the heart overnight. Number 4, adjusting your bedtime around nighttime bathroom trips. New 2025 research found that fine-tuning bedtime to someone's natural sleep rhythm actually reduced nighttime bathroom trips and improved uninterrupted sleep, with 0 medication involved. And number 5, if you and your doctor decide a supplement makes sense, low-dose melatonin has real evidence behind it, particularly a prolonged-release form specifically studied in adults 55 and older, which research has shown does not cause the grogginess or balance problems associated with the drugs we covered today. Here's the bottom line. These 3 drugs aren't dangerous because someone's out to get you. They're dangerous because an aging body processes them completely differently than the body they were originally tested on. The good news? You have real options. Options with far less risk and, in many cases, genuinely better long-term results. If this video helped you, do 3 things. Hit subscribe so you don't miss the next one. Drop a comment telling me which of these 3 surprised you the most, and share this with the person in your life who needs to hear it. And one final reminder, because it matters more than anything else in this video, never stop or change a medication without talking to your doctor first. This video is here to help you ask better questions, not to replace the person who knows your full medical history. Thanks for watching. I'll see you in the next one.